My name is Dr. Ido Weinberg. I work in Boston, Massachusetts, in Massachusetts General Hospital. I am a vascular medicine physician, which is also known as an angiologist in Europe. I'm an associate professor of medicine at the Harvard Medical School, and I'm medical director of a core lab called Vascular. The trial we're talking about is the STRIKE-PE study, sponsored by a company called Penumbra. I'm a consultant for Penumbra, so you all should know that. The reasoning behind this trial is that there is not enough data out there about real-world treatment of patients who present with pulmonary embolism and who are being treated with mechanical thrombectomy. And so the reasoning behind this trial was to obtain this sort of large, real-world, multi-site data about using mechanical thrombectomy, obviously by using the Penumbra devices for the treatment of pulmonary embolism. Full disclosure to all of you viewing who don't know what vascular medicine is or angiology, which kind of includes me some days, it's that I don't perform procedures. And so when I come and describe the Indigo Aspiration System, it's going to be sort of in more general terms. It won't be a technical discussion. But I will say that at the end of the day, it is a vacuum-assisted technology that allows removal of clots from the pulmonary arteries, again, by using a vacuum. There's also a computer element to this, a computer that is attached to the vacuum unit that detects when the catheter, the aspiration catheter, is actually in contact with clot, and only modulates the aspiration activity in such a way that's supposed to minimize blood loss. So it's supposed to engage only when the catheter is actually touching the clot versus not. And the idea behind this is basically that when a patient with pulmonary embolism presents with a degree of either hemodynamic or respiratory compromise, removal of clot should achieve relief of that compromise, and that's what the system is designed for. The study design will include 600 patients presenting with pulmonary embolism. The study is still recruiting patients. We're at about 320 patients. The study will eventually have 55 sites globally. The idea is to enroll patients with pulmonary embolism who will be treated with the Penumbra devices. Then patients will be followed for two purposes, basically. First, there's going to be the primary outcome, which, in line with previous studies, will look at the RV to LV ratio with paired imaging modalities, which is a fancy way of saying if a patient had a CT at baseline, they'll have a CT at 48 hours. If they had an echo at baseline, they'll have an echo at 48 hours, and so as to compare apples to apples. But in any case, the reduction in RV sizes is the primary outcome. There's also obviously a primary safety outcome, looking at potential complications of the procedure. But the presentation that we had at VIVA and at the VIVA conference in Las Vegas just a couple of weeks ago in November of 23 focused on not only on that, but also on functional and quality of life outcomes, which we are very excited about. And so the study goes beyond just looking at sort of the classic, I guess, long-standing surrogate markers of RV to LV ratio, and also is trying to kind of go beyond that, looking at patients' functional outcomes. These include simple outcomes such as perceived respiratory effort, but it also includes more than that. For example, it includes 6-minute walk time, for instance, and also we are looking at PE-specific quality of life measures, and the plan is to follow these out to a year. Let's talk about the results of the interim analysis of the STRIKE-PE trial. These results are looking at the first 150 patients who were enrolled. First of all, these patients were enrolled with intermediate and high-risk PE. These patients were obviously treated with the aspiration system for their pulmonary embolism. First, let's focus on the technical aspects. So the procedure time was around half an hour, 30-something minutes. The estimated blood loss was 286 milliliters, so something of that magnitude. Whether patients needed to stay in an ICU was left to the discretion of the operators and oftentimes followed local protocols. Still, it's worth mentioning that 38% of patients did not need an ICU stay. Focusing on the primary outcome, the RV to LV ratio was reduced significantly. You can imagine the patients came in with large RVs, again, with intermediate and high-risk PE, and these were reduced significantly within 48 hours. Not only that, but also the pulmonary arterial pressure, both systolic and mean, were reduced from the beginning of the procedure to the end of the procedure. Focusing on the primary safety endpoint, at 48 hours, there were 4 major adverse events, which is basically 2.7%. If you'll be able to look at the results themselves, you'll see that these events happened. Some patients had more than one event, but those were counted. And so there was a counting both of events related to bleeding and injury to the pulmonary arteries. Shifting gears completely and talking now about changes in functional outcomes. So it's worth mentioning first the Borg scale. For those of you who are not familiar with the Borg scale, it's a subjective scale of relative perceived effort, of a respiratory effort, basically. It's a scale. There are 2 types of Borg scale, 1 to 10 and 1 to 20. And at the end of the day, people are known to be able to assess the respiratory efforts in quite an accurate manner. And what we saw was that patients basically obviously came in with respiratory distress. After the procedure, there was rapid improvement. And by the end of to the point of follow-up that we are reporting, there was even more improvement in the respiratory effort. So the Borg score was lower. Lower means less respiratory effort, which is what we saw. The next functional outcome we looked at was the 6-minute walk test. We compared the post-procedural. You can imagine we didn't walk the patients before the procedure. So the post-procedural to the 90-day 6-minute walk time. And we showed a considerable and clinically meaningful difference of over 120 meters over 6 minutes. Finally, we used the New York Heart Association scale to kind of as a surrogate functional outcome. Obviously, this isn't a scale that is meant for kind of following functional outcomes after pulmonary embolism, but the idea is that you were trying to have the patients recall what they were able to do prior to the event, to the pulmonary embolism, then report their ability over time. And what we basically showed was that by 90 days, patients almost completely returned to their pre-PE capabilities according to the New York Heart Association subjective, I guess, assessment from a functional standpoint. Moving on to quality of life measures. So when you look at quality of life, those of you who kind of know how these are measured, you know that there are multiple sort of domains that you can look at. And at the end of the day, patients exhibited improvement of all these domains over time by 90 days. So to summarize the results, the primary efficacy endpoint showed a significant reduction in the RV to LV ratio. There was a significant reduction in the pulmonary arterial pressure. The major adverse events happened in 4 patients. And as you heard me say before, there were very nice improvements over 90 days in these first 150 patients in functional and quality of life outcomes. If I had to summarize these interim results and kind of think, how do I think about this? I would say, first of all, some patients will need a procedure. This study did not help us understand which patients need a procedure, but some patients will need a procedure. It seems like overall this procedure was safe. And also overall, it seems like patients who underwent these procedures improved from a functional outcome, which is what matters over time, very significantly. I will say that there's more for us to study because you could make the argument of whether, or you could ask whether patients really needed to have these procedures in order to improve. Obviously, that is the the holy grail in this field, understanding which patients need the procedures and the benefit of procedures over time. And indeed, this would be a place for me to plug in the STORM-PE trial, a randomized study that is currently kind of ramping up, that will basically try to answer that question by randomizing patients to receive either a procedure or anticoagulation while following various, again, both sort of classic outcomes, but also functional outcomes, including the use of activity monitors to really try and offer a sort of a rich kind of answer and kind of in-depth answer to this. So, definitely stay tuned. These results are very encouraging as a first step, and more to come.